Welcome to the PsychopharmaStahlogy Show, a special NEI Podcast series. In this show, Dr. Andrew Cutler interviews Dr. Stephen Stahl on the most controversial, novel, and exciting topics in psychopharmacology today.
Hello and welcome to another edition of the PsychopharmaStahlogy NEI Podcast. I'm Dr. Andy Cutler. With me, as always, is the wonderful Dr. Stephen Stahl. And today, we're kicking off a series that we're doing on relatively untreatable dimensions of psychopathology. So these are going to be some conditions that are transdiagnostic, don't necessarily have the best treatment options available, and things that we haven't talked about as much. And with us today is a good friend, Dr. Les Citrome. Les, how are you?
Great, Andy. Thanks for having me.
Well, we're talking about agitation today, and Les, you have been publishing on this topic for many years. I've learned a lot from you over the years. And Steve, welcome.
Thank you. I've seen Les over the years, and he is pretty agitated, so we'll go for it.
He's getting a little better. Yeah, that's true. Well, let's just start off. Basically, when we say agitation, people use that term all the time. What the heck do we really mean when we say agitation? What is that?
Well, agitation is a relatively broad term, which means increased activity verbally and physically. It doesn't necessarily mean agitation leading to aggression, and doesn't necessarily imply that the person's going to be violent. It just means they're agitated, they're uncomfortable. It's ego-dystonic, so someone doesn't like being agitated. And that's our hook, actually, into getting treatment for them, because they are uncomfortable. Now, if we don't do anything about it, then we can get the escalation from agitation to aggression and perhaps violence.
I see. So can we conceptualize this as a bit of a continuum then? Is there a trajectory to it?
Well, it could be. So someone who is initially mildly agitated can become more severely agitated if the stressors are still present and there's really nothing else that is mitigating the agitation. So that certainly can be the case. I like to intervene when agitation is initially present in its milder forms before it can progress. Now, sometimes it will go away by itself, but oftentimes it does not. So agitation is purely increased activity, either verbally or motorically or both. And that's quite different from aggression, which actually is threatening to other people or throwing things around, and very different from violence, which is someone hitting somebody else.
Is psychomotor agitation all agitation, or is it a type of agitation?
Well, psychomotor agitation implies something inside that someone is uncomfortable. So motor agitation just alone would be kind of unusual.
And we mentioned transdiagnostic, so it can be seen in many conditions, wouldn't you say?
Yeah, absolutely. So we can see agitation associated with schizophrenia, with bipolar disorder, and with dementia, and it's not rare. And I say transdiagnostic also because we can actually identify agitation/aggression/hostility, which is yet another term we can use, as being distinct from psychosis or manic symptoms or cognitive impairment. People can be agitated with Alzheimer's disease, for example, while having mild cognitive impairment or reasonably low levels of cognitive impairment. And that does not immunize them against being agitated. And we can take a look at the the symptoms, I should say, of schizophrenia and identify that hostility and excitement is distinct from hallucinations and delusions, and distinct from negative symptoms, and distinct from mood symptoms. So clearly, this is part of these different disorders, and we can approach them kind of universally with some agents and then specifically with others.
Somebody be agitated with depression or anxiety as well?
Oh, of course. We see a lot of people who are anxious seem agitated, and people who are depressed can certainly be agitated. There was a term, agitated depression, and we would use that term when describing someone who has a depressed mood and wringing their hands and pacing about and unable to sleep and so forth.
Right. Well, I guess one of the core symptoms is psychomotor agitation or retardation, so it is in the diagnostic criteria. Now, something you said that's interesting to me is it's not invariably aggression. You can have aggression, but it's not part and parcel one and the same. Is that correct? I think about that.
I would say so. The concern, though, is that agitation can escalate if you don't pay attention to it. So let's take the example of someone who has Alzheimer's disease and they're pacing. And that's about all they do. They pace about. It's distressing to them. They don't like to pace. They feel uncomfortable pacing, and it's agitation. Now, it's not hurting anybody, but they are pacing about.
Yeah, very interesting. Now, does agitation present differently in these different conditions, and how would you go about assessing this?
Yeah, so that's the age-old question, right? Why are they agitated? Why are they potentially aggressive? Well, it could be someone with schizophrenia. They're acting upon their hallucinations or delusions and that they feel threatened. That's certainly a possibility. Or, it could be that they have some comorbidity that we did not identify. Who knows? They may have a delirium. So the differential diagnosis is pretty long when it comes to agitation, and we need to identify the core source. No matter what the cause is, though, we need to address it.
Yeah, certainly. And so I would imagine that somebody with a dementia, the causes of the agitation, the precipitants could be very different as well.
Sure. Someone who has a cognitive impairment may be agitated because they don't know where they are. They're confused about who the people are that are around them. And frequently, we'll employ some behavioral approaches to their agitation when we can. So making sure there's adequate lighting, making sure that people are oriented with signage and clocks and calendars, and making sure there's no excess clutter in the room, make sure there's no excessive noise. So that goes a long way. There's a reason in nursing homes why name tags have the name of the function of the person in very large font, such as nurse or doctor or social worker. And that's to orient the person every time they have an encounter with a staff person, so there's less of a chance of confusion. And there's also a reason why someone enters the nursing home room saying, "Hi, I'm Dan, your nurse for today." Even though Dan, the nurse, may have been the nurse all month long, every day they have to reintroduce themselves. So those are some of the things that we do to help people maintain a sense of knowing where they are and have a less likelihood of becoming agitated because of fear. The other thing with dementia in particular is the oppositional behavior that can be present when someone is told to bathe or eat or take their medicine, when someone is confused about the need for bathing, eating, or taking medicine. So rejection of care can lead to agitation, and that's often the precipitant for someone ending up in a nursing home.
Can I ask what the difference is between akathisia, anxiety, and agitation? Are these kind of like different aspects of the same thing as you see it, or are they much different from each other?
Well, Stephen, I'm glad you brought up akathisia, because that's often a huge miss on our part, that we continually increase the dose of the antipsychotic in the hopes of addressing the agitation when in fact they seem worse. And that's because it's akathisia, which is iatrogenic. Akathisia is that feeling of inner restlessness that is uncomfortable, and it's manifested physically by pacing about, moving about, being unable to sit still. Unable to sit is I think in Greek, akathisia, and that can be confused for agitation due to other reasons. And there, the treatment is reduce or eliminate the offending agent.
Well, Steve, are there common neurobiologic mechanisms here, or common neurobiologic pathways?
Well, we're just beginning to understand that because it's been treated a little bit more symptomatically and phenomenologically because it's not a diagnosis. It's a dimension of psychopathology that fits with lots of different diagnoses, as Dr. Citrome has already said. But there's interest that certain pharmacologic agents now that either have data or approval seem to help agitation, at least in the dementia sphere. So rationalizing backwards, you can assume that those neurotransmitters are involved, and they would be things like brexpiprazole, which has been approved, and also the combination of dextromethorphan with other things, whether it be the one marketed compound, not approved yet for this, but approved for depression, with the bupropion, It's also been studied, with some other combinations. Maybe glutamate is involved, and maybe, if you will, some of the neurotransmitters. You could say, because brexpiprazole, for example, is in a group of drugs that you would not give to dementia, right? Except this is paradoxically approved for something for which it's also got a black box warning. I love that. But what's the property of brexpiprazole that is doing this? Is it the dopamine, or is it one of those other million different pharmacological things that we have?
Sure.
We've kind of wondered whether that hasn't a little bit more been related to some of the noradrenergic alpha-1, alpha-2 properties, rather than some of the other ubiquitous serotonin and dopamine ones. But so that's the answer to your question. Maybe alpha-1 noradrenergic, alpha-2 noradrenergic, and methyldiaspartate glutamate may be involved with the regulation of agitation.
Well, it seems to me just kind of broadly, and maybe the audience will resonate with this, that it's a bit of a failure of top-down regulation. Les, is that a way to think about this?
So the indication itself is agitation associated with. And the idea is that we can identify maybe something specific for a diagnostic entity, but in truth, probably it applies across the board.
Yeah. Well, we do have some treatments that are approved. As Steve mentioned, we have brexpiprazole for agitation associated with Alzheimer's dementia. We have a few treatments approved for agitation associated with either schizophrenia or bipolar disorder.
Yes, but they're different. So currently, the treatments that are approved for agitation associated with schizophrenia or bipolar disorder are for PRN use. The strategy there is to treat the agitation as it is present and decrease the intensity of it in the moment. And they work quite well, and we've been doing this for quite some time. These agents were tested amongst patients who were acutely agitated as PRNs, or stat doses specifically. Whereas the strategy for the Alzheimer's disease indication has been to, not as a PRN, but as an ongoing medication regimen to decrease the intensity and frequency of future episodes. So it's playing the long game, so to speak, and rather than PRN quelling the acute episode, is hopefully making life easier for them in the long run. It's a different approach. I think it's well worth considering.
Yes.
In reality, you need both. You need both something to work acutely and then something to work longer term. There is another product we didn't talk about yet, which is really interesting. I just learned how to pronounce it recently. Dexmedetomidine sublingual film. And dexmedetomidine sublingual film is approved for agitation associated with schizophrenia or bipolar disorder in general, whether you're manic or depressed, doesn't matter. And it's used as a PRN. Now, what do you do afterwards? Well, then you have to think of some other strategy. But what about those with dementia? Well, it's being tested in people with dementia with Alzheimer's disease as a PRN, and then we'll have the best of both worlds. We'll have something hopefully approved for use acutely in people with Alzheimer's disease, and we already have presently a drug now approved for ongoing use, brexpiprazole, with the potential of two others perhaps joining our armamentarium. So I think things are looking better in terms of FDA-approved agents for agitation associated with Alzheimer's in particular.
It's a paradox. Steve mentioned the paradox of the bolded box warning with brexpiprazole, which refers to dementia-related psychosis, and of course this is agitation associated. But the limitation of use for brexpiprazole for this is it's not to be used PRN. It calls it out in the prescribing information. The dexmedetomidine is interesting you mentioned because that's working through alpha-norepinephrine or alpha-adrenergic receptors. And it seems to me that maybe what's going on, in addition to a failure of top-down regulation, is kind of an overdrive of the sympathetic adrenergic nervous system. And so I guess there's a rationale to that.
Yeah, I mean, that's the thought. You know, it's thought that the locus ceruleus is pumping out too much norepinephrine, and one way of addressing that is through the autoreceptor on that norepinephrine neuron. So that's what dexmedetomidine does. But, you know, let's keep in mind, dexmedetomidine was originally developed as an anesthetic agent. So we know it can actually be used. And the idea here is using microdosing, essentially, of dexmedetomidine administered orally, sublingually, can do the trick in reducing agitation in the moment.
Well, that certainly
and
is.
Some of, like, for example, brexpiprazole has some alpha-2 agonist properties, but they're also, it's a little complicated because it's like you want to stimulate the presynaptic and you want to block the postsynaptic. So it's really the alpha-1 antagonist properties that may actually work as well. And alpha-2 agonists work for what other thing? ADHD, particularly the agitated and kind of ornery and difficult types of ADHD, right?
Yeah, it's good at calming hyperactivity. Well, speaking of this, Les, you've touched on something I did want to talk about, and that is I think probably a lot of clinicians have maybe confused sedating a patient with calming a patient, and the goal is not necessarily to knock them down or sedate them. Is that right?
Absolutely. When you knock someone down or sedate them and they're sleeping, everyone in the ED will be mad at you because now you have a bed blocker, someone who cannot be moved and who the inpatient unit won't accept for admission until they're, alert and awake. Otherwise, they're not medically cleared. So the last thing you want to do is sedate someone. Look, they'll need someone with them at all times to monitor them. They need help toileting. It's a real hassle if someone is overly sedated. So you don't want to do that. But I guess the best way to describe what we want to do is by looking at the long term. So in the long term, we want to decrease the intensity and frequency of agitation and aggression ultimately for our patients. One way to do that is by addressing part of their symptoms, and one of those is called hostility. So hostility is a driver of aggressive behavior, period. We've known this from research that has looked at rating scale scores of hostility and correlating that with the risk of actually engaging in some aggressive or violent behavior. We want to get hostility down. So let's define it. Hostility is an attitude that people find quite bothersome and irritating. It's looking at the world with a very negative way, and the positive and negative syndrome scale actually has a hostility item. And part of the instructions is that you also measure things that you wouldn't think are necessarily all that hostile, like sarcasm. So you wouldn't think sarcasm would be a terrible thing, but actually it grates on people's nerves. And if you are sarcastic all the time, you're not going to get along with people, and you're going to end up perhaps getting agitated and perhaps becoming aggressive. So we can use hostility as a marker of something we want to address. Well, wouldn't you know it? We have all this data of hostility scores from all the clinical trials conducted in schizophrenia and some conducted also in bipolar mania. And we can look at, can we influence the hostility score independently of addressing psychotic symptoms or manic symptoms or sedation? And we can. We can actually identify a specific anti-hostility effect for the second-generation antipsychotics in general. For this is quite marked, such as for clozapine, where we can reduce hostility and aggression independent of any reduction in psychotic symptoms, manic symptoms, and it's not related to sedation.
Are you saying that you can actually learn to not be hostile, or you have to be poisoned not to be hostile?
Yeah. Well, you can actually be treated to be less hostile. And we've done this quite successfully on the inpatient units at the state hospital where I used to work. And of all the antipsychotics that are available, I probably have the most experience with clozapine.
So you're saying it's a direct or specific anti-hostility action.
Yes.
That's kind of a novel idea, I would think, for a lot of our audience here listening in. Because traditionally, I would venture to say that traditionally people have used PRN antipsychotics, benzodiazepines, other kinds of sedating things to calm or knock people down. So it sounds like we've been really using a very blunt instrument here rather than a scalpel.
Well, it's actually complementary. When someone is acutely agitated, you have to address it, because otherwise someone's going to get hurt. But what are you going to do afterwards? Once they're calm, what are you going to do? Wait for the next episode of agitation? No, you want to decrease the risk of that happening again. And you can do that with the specific anti-hostility effect of the medicines that we have available today. Of all of them, clozapine is probably the best. but unfortunately, clozapine is not for everyone. What's second best is olanzapine. But generally, all of the second-generation antipsychotics can be demonstrated to have a specific anti-hostility effect. Now, this happens to be the case not only in schizophrenia, but also in bipolar disorder, where you can demonstrate a anti-irritability effect and an anti-hostility effect if you have the right rating scale being used, independent of a reduction in manic symptoms, and importantly, independent of sedation.
That's
actually it makes me wonder, have you ever seen anybody take the approved neuroleptic, essentially piprazole, and post-hoc analysis to see whether or not it was a powerful anti-hostility score? I've not seen that. Have you?
Well, yes. So I've spent the last decade and a half doing these post-hoc analyses. They help address this question.
For brexpiprazole?
Yes.
I missed it. Les, I missed it. Tell us more.
It's essentially the same playbook. You pull together the different studies. You look at a couple things, hostility item. You look at the PANSS excited component. You can talk about not only hostility, but also agitation over the long haul. But, this is not rocket science. Once you got the method down, you just, rinse and repeat here and show everyone that, hey, these medicines are a useful approach in addressing one of the most perplexing and problematic symptoms that we see.
Yeah. Well, most of the atypicals do have anti-alpha properties. They do have some antagonism at alpha receptors, either one or two. So there could be a common theme.
Absolutely. We never made these observations with haloperidol, and for
point.
good reason.
Good point.
So clearly the second-generation antipsychotics with their more complex pharmacology are doing something different than our older agents.
Is there still a role for benzodiazepines here, Les? Because I know they're still used.
So, yes, I would say so, as an as-needed medication. I hesitate to recommend benzodiazepines as an ongoing medication regimen, primarily because they stop working. There is a development of tolerance that is inevitable, and then there's the problem of missing a dose and then getting some rebound symptoms, which is a problem. And then what if someone runs out of their medicine on a weekend? Good luck to them getting a renewal. So I hate to get into that and place patients into that degree of jeopardy. But as a PRN, it's just fine. And in my private practice, I've routinely given prescriptions of, let's say, lorazepam, knowing that they'll only need one prescription per year and that they'll use it once or twice a week tops, and that's good for them. In the ED setting, where I've worked for many years, I would use a combination of agents, one of them being a benzodiazepine, the other one being an antipsychotic. In the old days, it was haloperidol. We'd call it the B52.
B52.
Yeah, haloperidol 5 and then lorazepam 2. I think we have better options today, and I think haloperidol is basically obsolete, and the other agents actually are much better tolerated. But, we use combinations, and look, if something doesn't work, I'm not going to repeat it with the expectation that it'll work. So that's the definition of insanity. You do the same thing over and over again, expecting a different result. So I would move on to another agent, another class of agent, and that's where I would move directly to a benzodiazepine. Today, though, with dexmedetomidine sublingual film, if on formulary, I would reach for that.
What about the role of intramuscular antipsychotics? We have some atypical intramuscular options.
Oh, short-acting?
Yes, let's say short-acting.
Yeah, you bet. So I would say the availability of olanzapine short-acting or fast-acting IM and ziprasidone fast-acting IM are superior to the alternatives. And it's just too bad that we don't use them as much as we should, and that we seem to be married to haloperidol IM with all its problems with the intermittent cases of acute dystonia. Sure, it doesn't happen with every patient, but it happens often enough that you don't make friends that way. And then someone who has experienced acute dystonia is going to be very reluctant to take anything else that you have to offer them.
Yeah, I know. Les, you and I have been working for several years on this, and ER physicians are still using the B52, the so-called benztropine for the B, and haloperidol 5 and lorazepam 2, that's where the B52 comes from. It's been a difficult process to try to educate and try to change clinical practice here. What more can we do, you think?
Well, I think we need to remind people that fast-acting intramuscular olanzapine and fast-acting intramuscular ziprasidone have been around for over 20 years. And now they're generic.
Yes.
And they're not costly. So that obstacle shouldn't be there.
Yes.
And
Yes.
that they work. And
Yes.
you know what? Patients prefer them. I never had someone ask me for an injection of haloperidol. Not once in my career did someone say, "Oh, Dr. Citrome, I'm agitated. Can you please give me a shot of haloperidol?" That never happened. But I did get requests from time to time for an injection of either olanzapine or ziprasidone because they had it before. They know it works in terms of helping them calm down. They realize that they're uncomfortable, and they tolerated that medicine very well. So they felt comfortable enough to ask for that. Now, mind you, I knew them, they knew me, but we had a relationship where they could ask for something that indeed was helpful to them and that they tolerated.
Can I ask whether you think that avoiding anticholinergics or discontinuing you have them on, it doesn't help your cognition much, and it doesn't help your alertness much to be anticholinergic. Do you think it helps induce more hostility or agitation? And if you stop those anticholinergics, does it improve it, or is this basically not irrelevant to the agitation argument?
So an interesting question that you brought up. Andy and I are card-carrying members of the I Hate Cogentin Club.
Yes.
So
no, so am I. I think I might even be vice president.
So if there's any opportunity to decrease the use of benztropine, I'll be there. It can't be done overnight in someone who's been taking it for a while, but it can be done gradually, and they'll eventually thank you for it because they'll finally be able to remember to thank you for it. So as you mentioned, benztropine can impair memory, and it also, by the way, as you know, increases the risk for developing TD if you don't already have it, and if you are unfortunate enough to have tardive dyskinesia, it can make tardive dyskinesia worse. There's no redeeming feature for benztropine other than intermittent use when you have to for dystonia. But even then, someone with chronic dystonia, I wouldn't want to give benztropine. I would send them to a neurologist for Botox. So the use for benztropine, I think, is very limited. But if we look at the universe of people getting antipsychotics, it's frighteningly high in terms of utilization.
Yeah, it's almost a third of patients are getting an anticholinergic. But I think Steve's put his finger on something very important, Les, and that is anticholinergics come in lots of flavors and sizes. There's many different drugs that have anticholinergic effects. And I can't help but think that he's 100% right, that if we can minimize anticholinergic burden, which is going to be cognitively impairing, it can even lead to delirious states, which of course are a big risk for this agitation. It can't be a bad thing to be minimizing anticholinergics. So that's a very important part of the management here, I would say.
I might just throw in something here now for advanced thought. If we start getting some of these procholinergic agents into practice,
yes.
one of which is coming actually probably in September, and it may not only come for the psychosis of schizophrenia, but for the psychosis of Alzheimer's, and possibly used off-label as soon as it's approved anyway. It's possible that these bad cogentins of the world that we are against in our club may actually block the ability of these new drugs to work because they are blocking the news. It's just something to keep in mind. We've never had to worry about that before, but I'm just throwing that in there in case you think about it in a few months.
Yeah, another reason to hate cogentin. So I think TD is good enough a reason to not particularly like cogentin. Cognitive impairment is the second issue that I would like to avoid with my patients who are already cognitively impaired. And lastly, should we wish to use these muscarinic agonists or positive allosteric modulators, whatever we'll have on hand, they won't work if you have benztropine on board, I don't think. Yeah. So we definitely have to pay more attention to this.
Well, as an older man, I don't like urinary retention or constipation either, just to throw that in there. But Steve, you raised an interesting point. I wonder if these agents will be calming in some way. That is fascinating. We know that there's the possibility of procognitive, especially with M1.
Well, Well, you know, Andy, there was a poster presented at the schizophrenia. Was it at CSIRS or was it at NEI Synapse? Must have been at NEI Synapse. Yeah, that's where I saw it.
That's a great meeting. That's a great meeting.
Wonderful meeting. I wonder who puts it on. Anyway, the meeting had a poster reception, and one of the posters was for the xanomeline trospium combination from the clinical trials, looking at the panexcitic component, demonstrating a decrease in agitation. Well, I'm not surprised. If you address the positive psychotic symptoms, you will address the excited component. I'd like to see if there is a specific anti-hostility effect, though. And
me as well.
I've been asking the company to do this kind of analysis. Maybe they'll do it now, but it would be something of great interest. And does it do better? Does it do that job better than other agents? So we don't know. So I can't wait to get hold of that agent and see for myself.
Well, not only that, Les, but you bring up a very important thing that the listeners should all be helping us with, that the three of us have been doing for what we call in the UK donkey's years, which means a long time, and that is to look for a new indication of a drug with a new mechanism, even though it's coming in the door of a different mechanism. So yes. I will lay you odds right now. I don't think anybody's going to take this bet against me, but maybe one of you will. I'm going to bet that the indication of muscarinics, pro-muscarinics, will not just be limited to psychosis, but there will be some unknown and possibly important thing, just like how these agents crept up in bipolar depression against all odds and any theory.
Yes.
And made perhaps their largest impact in mood disorders and not in psychotic disorders, particularly the new ones. I think the same thing's going to happen with these drugs. And the way to do that is to put it out there and observe and see things that are a little unexpected and are different dimensions of psychopathology other than the core one for which it's approved by the FDA. And with that, we may be able to expand. I just have a hard time believing that cholinergic receptors are in the brain only to control psychosis. I think that there's lots of them all over the brain. And, of course, we have M1 drugs and M4 drugs and combination drugs, et cetera, which is part of the other story. So anybody take me up on that and say, no, it's Dr. Stahl, it'll only be psychosis. Is anybody going to take that position against this idea?
No way. I actually look forward to hearing from our colleagues when these drugs get on the market, because I've joked for years, Steve, you've heard me say this, I've always done these trials that gets drugs approved, so I do the research that gets it in the clinician's hands, and then the real research begins.
Yeah.
Because they'll give it to lots of patients, and they'll observe, and they'll tell us. And you're right, the wisdom of a good clinician really carefully observing will tell us things about how these drugs work.
And so having said that, therefore, there's possibly on the horizon an anti-hostility drug or some sort of a drug for calming without sedating right in front of us. But it's not approved for that. Yeah. But if it works, it'll work as, many of the themes of this podcast, and I know Les is a big champion of this, that basically the psychiatric disorders are dimensions of psychopathology, and they cut across many disorders. And so when you find a treatment for a dimension of psychopathology in one disorder, it often works if that same dimension shows up in another. Yes. So be on the lookout. This is what's fun about being a psychiatrist today. And like Les, I can't wait to get my hands on it either.
Yeah. Guys, there is another drug in development that is kind of interesting. There is a sublingual deuterated form of lumateperone that is being developed for dementia-related psychosis, but they're also going to look at it for agitation associated with psychosis. And that's intriguing because lumateperone has shown a much lower propensity towards some of the things that we worry about with atypical antipsychotics, principally movement disorders, especially in the older population.
Yeah, so it's interesting. I don't think it would lead to akathisia, so we don't have to worry about that. We do know that lumateperone, though, is associated with sedation. So I'd like to see an independent effect on hostility that is quite different from, let's say, the anti-hostility effect that's independent of sedation.
Yeah, it's a different kind of sedation, though. It's not an antihistamine sedation. It's a 5-HT2A kind of sedation. So you're right. Yeah, it'll be but the point is that we may have several options here, and that may allow us to individualize to some degree. Do you think that's possible, that we would use different medicines for different agitation types or patients with agitation?
Well, I think there's a huge advantage for FDA approval for an indication of agitation associated with blank. And if you have that FDA approval, then you can have salespeople go out there and talk about it, and more people will know about it, and they'll be more likely to use it. So I think that's a really big advantage. So for example, I did a study of sublingual acenapine together with colleagues actually in Syracuse, looking at sublingual acenapine in all comers who are agitated to an emergency department. It was better than placebo and worked really quickly, but it doesn't have the approval. So it's a rather niche use of acenapine sublingual. People who've used it liked it and continue to use it, but they're very few in number. Yeah. I could imagine if this was approved for the indication and there were salespeople out there talking about it, that it would be much more utilized.
Yes. There's also the olanzapine Zydis preparation. I know you've looked at that as well.
Well, yeah, I don't buy that one. So here's where there's a huge misunderstanding when we look at these orally disintegrating tablets. Acenapine sublingual disintegrates in the mouth, but it's absorbed in the mouth. It's absorbed sublingually and gets into the blood faster. Immediately. Yeah. Zydis, olanzapine Zydis, the oral disintegrating tablet, dissolves, but you have to swallow it before it gets absorbed in the GI tract. So it is slower. There was some thought that it would be faster acting, but it's not. And pharmacokinetically, there are very minor differences between regular pills and Zydis. Maybe there's something more to it at the higher doses, but clearly it's not the same as sublingual absorption as seen with acenapine or with dexmedetomidine sublingual film.
Right, and this sublingual version of lumateperone may follow suit, as you're saying. Well, I want to take a little bit of time. Of course, we're psychopharmacologists, and so we're focusing a lot on medications. But I want to talk a little bit about non-medication strategies here. And in order to do that, Les, maybe you can talk a little bit about the Beta project that you've been involved with some others.
So Beta is not something I was directly involved, but I learned a lot from. Yes. And I worked with colleagues who were authors of the best practices in treatment of agitation. It was a group of emergency department psychiatrists and emergency room department physicians. And they got together and came up with a way of dealing with agitation that is multifold. They are big advocates of verbal de-escalation techniques. Now, this works in several ways. You can get someone calmed down without the need for additional medicine, or you can get them calmed down enough to agree to an oral medicine. And you've avoided the IM injection. If you have to, you will give the IM injection. But that comes with some risk. If someone is refusing to accept a medicine and you're going to give them an injection, you need 5 people, one for each limb and one to do the injection. And if you don't do that, someone is going to get hurt. So Project Beta emphasizes the need to, get all your ducks in a row and try to diffuse the situation the best way you can and try to get them to agree to something oral, because although it is slower acting, it still works. And it's just waiting a little bit longer, but you've gained a lot in terms of someone knows help is on the way, that they have something on board, and that they can expect to feel better. And it relies on the premise that anyone who is agitated is uncomfortable. They don't like being agitated. It's an ego-dystonic state, and they want some degree of help. So there's some verbal de-escalation techniques allowing patients to talk about what's upsetting them, also offering them something, a glass of water or a sandwich. We used to call it sandwich therapy. And it goes a long way. You're offering something and you're listening to them, and that can go a long way. Project Beta also made the bold statement that we should use second-generation antipsychotics approved for the purposes of agitation over and above the older agents, including haloperidol. So it was all agreed to that this was the best way to go close to 20 years ago.
Well, it's interesting. This was an American study, I assume, Les. Is that right?
Project Beta was an American project.
So one of the things about de-escalation techniques is that it's not so common to be used in the United States. And we actually recently, over the recent few years, have gone overseas. And it's very interesting. I know you have too, but I still work around state hospitals. And we use this thing called seclusion and restraint, right? And you have restraint rooms, and you tire people down, and so forth and so on. And this is where most of the staff injuries that occur in a fiscal year will occur. And so when you tell people overseas about this, they think you're frickin' nuts. And they thought that basically these seclusion rooms were something that was in our museum. They don't have the seclusion rooms overseas. They do a very good job of verbal de-escalation, much better. It's part of their culture. Now, it does take a little more staff because when somebody's agitated, they may even have 3 people involved. They have one person on each arm. They don't use, mechanical restraints, like we do. They use what's called physical restraints, whether someone might be on your arm and the other one on the other arm, and then someone talking to you to try to bring you down. And they use a lot less medicines and a lot physical restraints than we do. It can be done, but for some reason, it's just not part of the American culture compared to... When I told this to people in the UK, in Ireland, in Italy, in Austria, I showed them pictures of what we did. They were shocked, like you're 19th century psychiatry. And so just because I'm a recovering psychopharmacologist doesn't mean that I can't actually be a human being and listen to these non-medication stuff. We're just too quick to put a needle in somebody and call it a day and tie them up and leave them alone. So, shame on us. There's something we can learn from our colleagues overseas and from the Beta Project that Les was talking about.
Well, I'm reminded of something a professor taught me once during training. Don't just do something, stand there and assess the situation, if you will. But we are in a hurry, in a rush sometimes. So it seems to me, Les, something you said earlier that struck me, first of all, that this is ego dystonic. Agitation is distressing to a patient. And secondly, assessing the environment and assessing the situation more, it may be something very easily remediable, if you will. Perhaps it's a conflict with a roommate, or it's a certain person is telling you to do something that doesn't have to be done right at that moment. It could be the temperature's too hot. It could be the music's too loud. It could be the food is too hot. I mean, I can imagine a number of things in the environment that maybe we need to do a better job just kind of taking our time and assessing.
I think you're right, Andy. If we look at what results in agitation/aggression, it could be a product of a psychotic process. It could be a degree of impulsivity and lower tolerance to things that irritate a person. Now, God knows I'm irritable. And so things tick me off. And I would imagine if I didn't have enough cortical control, then I would, get into trouble more often. And lastly, there's also the aggression from psychopathy, which is different, which we didn't touch upon here today, and we don't have any medicines for that. But that sometimes gets into play in combination with impulsivity and in combination with psychosis.
Well, we've talked about assessing the environment, about non-pharmacologic interventions. What about the role that people in the patient's environment, maybe caregivers or family members, how can they help us with identifying and managing agitation?
Well, if they have a tool on hand to help when this happens, they'll feel a lot more comfortable. So I think having, whether it be a pill at home, in case of emergency, break glass type of thing, then that's very helpful, keeps everyone calmer. So making sure that's available. And then also providing some tips about what are triggers that, really tick off your son or daughter when you talk to them. And it works both ways. What does your son or daughter say that ticks you off? And then that escalates into a problem. So I have often referred families to NAMI in order to learn more about the disorder, more ways of learning about how to manage the disorder, and the day-to-day life of someone living with a psychotic illness and how to best deal with that. And providing some concrete ways of addressing that goes a long way too. But having that medicine available at home, I think also is very helpful in terms of reassurance.
Yeah, the dexmedetomidine sublingual film you're talking about currently is to be administered in a healthcare environment, but I believe the company was looking at an at-home use for that.
Yeah, they were. So here it's a matter of establishing to the FDA, convincing them that it's safe. Yeah. That it's effective, I think no one has any question. But is it safe? Can it be given at home and at what
But
dose?
also, your concept of how to communicate with someone and how to listen, I don't know if you've had this, I'm sure you've had this experience that I've had many times when the family member says, can't you just convince them that this is not real? Can't you just tell them this? And the answer is no, I can't, because your perception is your reality. And so teaching them ways to validate the person's experience without feeling like I'm agreeing with you, trying to look more at not is this real or not, but it must be terrifying to have this belief or this hallucination. So reframing
exactly.
it, if you will, yeah.
Yeah, so I really like the way you said it. It must be terrifying to have this thought. I mean, that's very empathic and could really demonstrate to the person experiencing this thought that you really care about how they feel and not about the thought itself.
Right, or in the case of agitation without psychosis, it must be uncomfortable for you. It must be scary to be out of control or to be this agitated. It seems like a good way to gain some empathy, too.
Yeah. Right, or pacing about. It must be uncomfortable to have to pace about.
Very interesting. So what are there some other unmet needs that we haven't addressed? Some other things that we need to think about that maybe we can do better in the future here?
Well, I think we can circle back to the idea that our interventions today are multifold. You know, we talked a bit, probably not enough, about the verbal de-escalation techniques and ways of interacting with people that don't tick them off. So we can all use a few more lessons regarding that. And then the availability of some newer psychopharmacological agents that do not require an injection, which would be easier to offer someone, and they'd be more readily accepting of it. I think that's certainly a big help, but we don't use them necessarily because maybe they're not on formulary, maybe we don't even know about them. And so the response in EDs is often, let's just give a shot of the B52. Yeah. I think that's a mistake.
Yeah, Steve had mentioned dextromethorphan earlier. There is a version of dextromethorphan in combination with quinidine, which is there to prevent the metabolism, the breakdown. It blocks CYP2D6. That's approved for pseudobulbar affect, which classically was pathologic laughing and crying, but actually one of the older definitions was emotional incontinence. So it really can encompass agitation, failure of top-down regulation of emotional discharge or inappropriate emotional discharge. And there is the newer form that Steve had mentioned, dextromethorphan combined with bupropion, the old antidepressant, which blocks 2D6. Now, this has a higher amount of dextromethorphan in it, and it is actually being studied right now, and this would be a chronic use, not a PRN use type medication.
Yeah. You know, Andy, I was very surprised the FDA did not approve that right off the bat. So they have an acute study that demonstrated efficacy, and they have a prevention study that also showed efficacy. So I think it's a winning strategy. It works acutely.
It does work acutely.
Seems, and also continues to work. And continues to work in reducing the frequency and intensity of these agitated episodes. So you have the best of both worlds here. But the FDA went back and said, no, we want another acute study. So they're going to get that other acute study, and fingers crossed. Yeah,
I think that would be a very nice step forward. You know, to be able to have a non-antipsychotic or a non-benzodiazepine option, non-injectable, as you've said, would be wonderful. There's finally one topic I just want to touch upon, and that's cultural sensitivity and cultural issues. Obviously, both the presentation of agitation is going to differ culturally. The assessment of it and the management of it, and again, when we're talking, of course, about verbal de-escalation and working with the patient, non-pharmacological treatments, what would you say are some cultural issues we need to be aware of?
Well, sometimes we react to people not based on the phenomenology, but based on what they look like. And that's a real problem. And we rush to judgment on people's appearance, and they may be given medicines above more frequently. Yeah. That is something very real. And it's ingrained, it seems, in our society, at least in the U.S. So we need to do something about it. One of them is being aware of our own ways of looking at people and making judgments based on how they look.
That's an excellent point. And of course, people express distress differently in different cultures. Some cultures, people will use physical terms and will not talk about emotional distress, for instance. In some cultures, things take on a religious tone, for instance. So I think we have to be sensitive and listening carefully to what people are saying, how they're saying it, and put that through sometimes a cultural lens or a cultural filter. Does that make sense as well?
It does. So this is going to require reframing all sorts of preconceived ideas that we have.
It might also help to have someone of the same culture present, someone who, of course, if there's a language barrier or a language issue, but also cultural issue. And it might be reassuring for a patient of a certain culture if it's all white men standing around you that's a different situation from having people of your culture there who maybe can help translate or diffuse a situation.
Yeah, so one of the more helpful people on our care team when I worked at the state hospital was the peer advocate. Now, there was only one or two of them to go around for a whole hospital, but it was very helpful to have them come to the unit and have a chat with some of the patients about what's going on. And they would tell the peer advocate a whole lot more than what they would tell the staff, even staff who shared similar ethnic characteristics to the patient.
I see. Yeah, I think we all will let our hair down a little bit more with a peer, won't we? Yeah, that makes sense. And especially it's helpful for someone who's been through what you're going through and can speak to it. Yeah. Okay, well, I want to say this has been a tremendously interesting conversation. Unfortunately, we're running out of time. Steve, any final thoughts here about this untreatable dimension of psychopathology?
Psyched that Dr. Citrome has dispelled this myth and given us many options.
Yes, me too. And Les, what final thoughts do you have for our listeners?
Well, first off, I want to thank you, Andy, and thank you, Steve, for having me here on this podcast and offering an opportunity to talk more about the need to think in more modern terms about what we have available, and to learn from what's been used with success in a variety of other settings. Maybe we can apply it to our setting.
Well said. Well, I think that we do have medications available. I still think people may not be utilizing the newest tools that we do have, many of which you've elucidated. And I think it's an exciting time because, as we've mentioned, there are some other medications in development here. But hopefully we've given the audience a framework and we've given some information that's going to be very helpful in thinking about and approaching agitation in the whole range of patients we see, because practically the whole DSM is associated with agitation, as we've said earlier. Well, I want to thank you, our listeners, for tuning in. Please, for more podcasts, you can find our NEI podcast and especially the Psychopharmacology series wherever you get your podcasts. As I mentioned, this is the first in a series. We'll be doing several podcasts on various less well-treatable dimensions of psychopathology. And for more educational offerings, please go to our website, www.neiglobal.com. Thanks so much and good luck with your patient care. Thanks, Steve. Thanks, Les.
Thank you for joining us for another episode of the NEI Podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit NEIglobal.com.